this year. So part of it, what I'm going to present today, this heading is so catching that common symptoms, uncommon diagnosis in dialysis patients. So what I'm trying to highlight here is that when a patient comes to you in a dialysis unit and he complains of a common complaint can be anything like a chest discomfort. It can be anything like back pain, fever, itching, headache, or something like a knee pain, or a loss of balance while walking. So these are very commonly told by patients when they come to the dialysis unit. There are certain clinical syndromes associated with this particular complaint. Suppose it's a chest discomfort, we first think about cardiac causes. If you're complaining of something like fever, the first thing to come in mind is whether the patient is having hemodialysis catheter and whether it is catheter-related fever. Or if the patient complains of anything like an headache, you're always interested to know whether the patient is having high blood pressure. So what happens is certain patients have similar complaints which they tell time and again. So there's some patient who has got something like a knee pain is diagnosed with some particular arthritis. Then any number of times the patient complains of knee pain, the first thing which goes in the mind of the dialysis technician or the doctor is that the patient has got arthritis anyway, it is because of that only, and they give the same repeated treatment for the same symptomatology. So today's topic highlights that there may be sometimes uncommon diagnosis hidden in common symptoms. So I thought to bring this topic rather than elaboratively in a text way, we have tried to put in clinical scenarios and try to explain each point. So let's start with our case 1. It's a 38-year-old male who is in hypertensive, a diagnosed case of IgA nephropathy leading to chronic kidney disease. Started on hemodialysis 3 per week via a right IJV perm cath. Now the patient is on regular follow-up initially, and recently patient is not following up regularly. So he's complaining of occasional retrosternal burning sensation. So the complaint here is retrosternal burning sensation. So behind the sternum in the upfront, some burning is there. Whenever you think about retrosternal burning sensation, the things which come up in your mind is commonest being gastritis, so any sort of acid reflux. You've got an acute cardiac syndrome like myocardial infarct or a heart attack. You can have peptic ulcer disease, so some gastric ulcers or duodenal ulcers causing retrosternal burning sensations, or any sort of mediastinal mass lesions which are in and around like esophagus or any lymph nodes, lymphomas. So all these symptoms can cause the retrosternal burning sensation. So going back to the previous slide, this was the complaint given by the patient. So initially, in view of the patient, they had done an ECG, which they found that the patient is not having any problem. So initially, they treated the patient as gastritis with some antacids, and the patient felt better within a few days of treatment. So it was considered as gastritis. Now the week comes to an end. The patient comes now with complaint of intermittent fever. Now the patient has got, as we said in the first case, a perm cath in place. So in view of the catheter, the first diagnosis because of fever was thought about is catheter-related bloodstream infection, that is CRBSI, was considered. Now the blood cultures were sent and empirical antibiotics like meropenem 1 gram and vancomycin 1 gram was given, a gram negative cover and a gram positive cover. The fever subsided, but he complained of occasional left-sided lower chest pain. Now the incident has come to the second week and the patient now sometimes complains of left-sided lower chest pain. So the retrosternal burning sensation has come little less, but the fever comes and goes. So fever reappeared after 10 days and one more course of antibiotics was given to this patient. So in view of this up and down course, chest X-ray and ECG was again advised to the patient, which he was not ready because of financial issues. And also his relative mentioned that he had this retrosternal burning and ECG was done previously 2 weeks back, which is normal. So we don't want to repeat it. So this left-sided chest pain may be cramps. So we will go home, apply some balm and then wait for some time and see whether it is improving. Please do not do chest X-ray and ECG. So in view of their request and the financial issues, he was post dialysis session on antibiotics. The patient was sent home. This course continued for 6 weeks, and this time the patient had this on and off fever. It was done by the casualty medical officer was there at that moment, and it was reported normal within the limits. Patient was explained the need for removal of perm cat in view of repeated fevers and was referred to higher center. So since the patient was having repeated fevers and the perm cat being the cause, so that was considered that there should be a removal of the perm cat. And in view of all this, from the peripheral center, the patient was sent to the central center. Now here when the patient arrived, the WBC count of this patient was 23,400. So in spite of whatever antibiotic treatment the patient received, the count was very high. And ECG was showing some small QRS complexes and X-ray showed a dilated heart. So now the X-ray was done and the X-ray showed a dilated heart. There was a high count and some small QRS complexes in the ECG. You must keep in mind that this whole episode has passed around 1.5 months. Now the patient was referred to the cardiologist who performs the 2D echo. So when you look at this X-ray, you can see that the heart is very dilated. And you can see in the 2D echo that there is a effusion, there is a fluid there in between the heart and the pericardium. So the patient had pericardial effusion. And one more thing to remember is when the pericardial effusion becomes more and it suppresses the pumping of the heart, it can lead to something called as a cardiac tamponade, which is having what you call as that intermittent hypotension. When you look at your jugular veins in the neck, it will be dilated, and whenever you try to listen the heart sounds, you will feel that it is low sounded, muffled sounds. So this sort of a combination in the presence as well as this particular scenario, the 2D echo revealed moderate to severe pericardial effusion, which was impending a tamponade. So basically, the patient had a collection around the heart. So because of this, the cardiologist intervened and put a pigtail in this to drain the fluid what he is seeing on the 2D echo. But when he drained the fluid, it turned out to be frank pus. And this pus was sent for culture, which grew Klebsiella. And according to the sensitivity, the antibiotics was given. After completing the course of antibiotics, the patient became better, the fever settled, the count settled. So what we understood here in this case is that the patient presented with a chest pain-like symptoms, retrosternal burning. Initially diagnosed as gastritis. Patient was ECG was taken, which was normal. Later on, he was advised X-ray but not done. Again, the patient presented in casualty with chest pain, then referred to higher center in view of the symptoms and repeated fevers, and then found to have a pericardial effusion, which was then found to be infected, and then treating the same, the fever settled. So the symptom was standard chest retrosternal burning, but the diagnosis was something really surprising as a cardiac tamponade. So what are the things we learned from this case in points to ponder? So here what was important was if the patient would have allowed to take an X-ray early, we could have found the dilated heart on the X-ray, and that would have guided us to go in one direction. One more thing which is important is all fever which is not dialysis catheter fever. So if a patient was got a perm cath or a catheter in place, does not mean that that particular fever is because of that. There can be many other causes of fever in the same patient. Early specialty consultation. So sometimes it is important that we refer the patient early if there's a particular symptomatology to guide us. Once we came to know that it's a cardiac related problem, we called in the cardiologist early rather than treating with antibiotics. He could put in an interventional pigtail catheter, and that led to the draining of the fluid and better and faster recovery of the patient. And repeat ECG when symptomatic. So what happens is that in a patient who has done an ECG couple of months back, and if the patient presents with chest pain, most likely the bystander will tell you that the patient is having acidity and that is why the chest pain. and we had taken an ECG 2 months back, which is normal. So please do not repeat the ECG. But it is our duty to talk to them, reinforce and make them understand that every retrosternal burning is not acid peptic disease. There is always a possibility of a cardiac cause in that. So ECG is important. And we all know that the most common cause of death in chronic kidney disease is cardiovascular disease. So this is what we learned from case 1. So let's go to case 2. Case 2 is a 49-year-old female. She is a diabetic, hypertensive, chronic kidney disease on maintenance hemodialysis for twice a week. Now she came with lower back pain. On history, we had got a history that she had a tumbling over a stone next to her house and a fall few days back. But there was no external wound when she spoke about this to us, that there is a back pain. On clinical examination also, there was no tenderness, no such symptoms, and she also said that she has a urine output of 400 ml per day. Now, when we discuss about back pain in a dialysis patient, the common things which come in our mind is whether the patient has got vitamin D deficiency, which is very common in all normal people also nowadays for lower back pain. Then there is osteoporosis, osteoarthritis because she is elderly, presence of hyperparathyroidism, or there is a presence of any disc-related bulge or disc-related disease, or there can be a possibility of an infective etiology, or commonly which some patients can have a fall and a trauma. So here the patient had a symptom of trauma, just a fall few weeks back. So we all took it in that sense, and there was nothing to indicate any of the other causes. The patient was given tramadol 50 milligrams and paracetamol 500 milligrams for relieving her pain. Why was not a good painkiller given? Because patient still had a urine output of 400 ml. So we wanted to preserve the residual urine output. So in that case, we continued with paracetamol and tramadol. Now she felt a little better, and we continued the medication for a week, and patient continued her dialysis as per schedule. Now she comes back to casualty 3 weeks later. Now after 3 weeks when she presented, she also had an additional element of fever to the lower back. Now in between, when she complained of this back pain, we had all asked her to see an orthopedic in the local hospital itself. And they had advised an X-ray lumbosacral spine. And when they took that X-ray, it was reported that it has got lumbar lordosis. Lumbar lordosis means the natural curve of the particular spine is absent, and this is because of the muscle spasm and tension around the spine in the lumbar region. And there was a supposedly doubtful compression fracture at L4 vertebrae. So in view of her ongoing symptoms, which was going on for the last 3 weeks, 4 weeks, in fact it was dragged up to 3 months, she was referred to a higher center. Again, at the point of 3 weeks in casualty when she had this issue, she was advised to undergo a repeat X-ray, which she had denied, and we were actually compelling her to conduct an MRI of the lumbosacral spine for a better diagnostic utility. Spine best is MRI versus X-ray in identifying any other pathology in the spine. So this is what we found in the X-ray. There was a doubtful compression fracture of L4. Not doubtful, it's quite evident, but it was confirmed on the MRI where the red mark is showing it's a compression fracture, and there is some oozing and some sort of collection around this particular vertebrae which is compressing onto the spot. So MRLS spine was done, which showed vertebral body compression, fracture at L4. There is discitis, that the disc is inflamed, and pus collection. So for this, she underwent a surgical decompression surgery in the higher center. During her stay in ICU, she developed sepsis, which turned to severe sepsis and septic shock, and eventually she then succumbed to her illness. So here the point to be addressed is the patient came with a common complaint of back pain. With no external injury, with a small history of fall, you are biased to think that the pain is secondary to the sprain or because of the fall direct impact on the back. Patients definitely have some vitamin D deficiency, some osteoporosis. So we supplement them with calcium and other supplements and local treatment. But when the patient complains that the pain is persistent, it is important to consider another diagnosis in this scenario. And that is what exactly by doing a proper imaging, we could identify that there was a septic focus there, which was then turning into an infection and pus collection. So what are the points we understand from this case? That whenever you got repeated symptoms, you must not be overlooked. Definitely, you have to consider again your clinical acumen to understand why it is happening. All the dialysis patients, when they come down to lie down on bed and if they complain of lower backache, please make it a point to lift up their dress under cover and see whether there is any local inflammation, local rise in temperature, or any other bulge in the back. That are the clinical signs which you can pick up to understand this is a different pathology than the one which you are considering. Imaging definitely important because here is the imaging which helps us in identifying the cause. And painkillers, very important. Whenever you are giving painkillers, you should always find out whether the patient has residual urine output. If it is present, we should try avoiding high-end NSAIDs and try to contain our drugs to paracetamol and tramadol. So with this, we come to case number 3. Now here is a 39-year-old male. It's a case of IgA nephropathy, chronic kidney disease, on maintenance hemodialysis via pump cath. Now he is worked up for transplant. So the patient is getting ready for transplant and the patient now complains of fever, chills and headache. Now when there is fever, there is chills and headache, the patient's vitals showed a blood pressure of 210 by bar 110 of mercury. So there was definitely hypertension, a sort of accelerated hypertension. So antihypertensive medicines were given. Even the dose were hiked to adjust for the future blood pressure control. Empirical antibiotics were started in view of pump cath and fever chills present. But this time the technician or the doctor concerned on duty had not sent any cultures at this point of time because it was sort of a straightforward case of accelerated hypertension with infection secondary to the catheter. Now the fever subsided, but it reappeared after 4 days. Now the blood culture was sent, which was reported later as no growth because already the antibiotics were administered to this patient. Now in view of the ongoing fever and the patient is also due for workup or is going on for transplant, so hence the patient was advised admission and started on higher antibiotics and supportive treatment. The fever continued. Since planned for transplant, the pump cath was removed and sent for culture. Again, there was no growth in that particular catheter tip also. But fever was on and off with waxing and waning symptoms. The blood test showed only very mild rise in WBC. So it was just about 13,000 count, just about little above, but patient is already on antibiotics. Sometimes the fever comes in once in 2 days, 3 days. It's just an intermittent fever. But he is feeling very fatigued. Now, because when we discuss fever in a dialysis unit, the first thing which comes in our mind as always is dialysis catheter related fever. What we call as catheter related bloodstream infection. But common causes which we think about fever is infective because infective is the commonest cause of fever. It can be bacterial, fungal, and non-infective causes when we look into, we talk about like patients who have got myocardial infarct can have a fever, patients who have got autoimmune diseases can have fever. So these are some of the non-infective causes of fever, common in the dialysis population if they are because of these about conditions. And some uncommon causes are those in where the patients are having some rare infections or patients are having drugs, medicine related fever. Host can mute the external sound, please. Host can please mute the external sound. Yeah, thank you. So these are some of the causes of fever in dialysis patients. Now, looking back at our patient, we have got a fever which is on and off with waxing and waning symptoms. So in view of ongoing fever, X-ray chest was done, which was not showing anything specific. An HRCT chest and abdomen was done. So because the patient is for transplant, we don't want any cause of fever. So we went ahead and did a CT of chest and abdomen, which did not show any abnormality. A routine cardiac evaluation for transplant workup was done, in which the cardiologist picked up on 2D echo the vegetations on the valves. So when you see vegetations on the valve, these are infective vegetations. The diagnosis is infective endocarditis. So now we came to know that the fever was not because of the catheter-related infection, but it was secondary to an ongoing process in the valve whereby the patient was having infective endocarditis. It was treated with antibiotics and taken for transplant after 3 months. Just to give you an idea, this is very common that at least 4 to 5% of the cases of infective endocarditis are commonly found out in patients specifically who have got dialysis catheter-related infection repeatedly or who have catheter in place. So they present mainly in the brain, like it can present with a stroke, they can present with abscesses because of the infective embolus from the valve vegetations, which can go and cause this. Patients will have rod spots in the eyes, which is diagnosed on fundoscopy. You've got congestive heart failure, valvular dysfunctions, arrhythmias, and abscesses in the heart. In the kidney, you can have an acute kidney injury and a glomerulonephritis. You can have arthralgias, osteomyelitis, like because of the vegetations entering the bone. The skin lesions are Janvey lesions and also painful nodes in the hand, palm of the hand, and embolic complications that you can see the vegetation pieces are going in the blood and it can go to any of the organs like spleen, lung, kidney, liver, or in the nails we can see that as splinter hemorrhages. And other symptoms commonly these patients can present is fever. They can have a mild hepatosplenomegaly and signs of metastatic infection. So these are some of the symptoms of infective endocarditis, but it has to be picked up on clinically with a course where the patient's fever is not settling for a few days. And when you go for what is called as pyrexia of unknown origin, and when we do different investigation to identify the fever, 2D echo is one of the investigation in which sometimes if the vegetations are large enough can be picked up on the 2D echo, or it can be picked up very well on transesophageal echo. That is when the echocardiogram is done via the esophagus. So this transesophageal echocardiogram. So what did we learn from this case? So in this case, we understood that all fever is not catheter-related fevers. Repeated episodes of fever should prompt to look for other causes. Blood culture is important in the first instance. So whenever you have a fever in the dialysis unit and the patient complains of the same, whether at home or in the unit, it is important to send the blood cultures. And wherever required, we must consider to do the counts, the CRPs, and the imaging to identify or localize the cause of fever. So this is what we could gather from this case, which was seeming to be a catheter-related infection, when on evaluation ended up with an infective endocarditis. The common symptom was an uncommon diagnosis. Now coming to case 4. Case 4 is a 65-year-old female, the diabetic chronic kidney disease on maintenance hemodialysis 3 per week. Now here what happens is the patient is complaining of mild fever, sometimes evening rise, sometimes it is mostly followed in the next few weeks by very less appetite. So she lost appetite for food. She was having dry cough since 2 weeks. Now the X-ray test done at that point did not show any changes. So, and also the fistula site was clean. No other positive signs were present. The patient was routinely treated as a upper respiratory tract infection and she was given antibiotics like levofloxacin. After 5 to 7 days of levofloxacin, the fever did subside for a few days, but the dry cough kept on happening occasionally. The fever also started coming up on and off. But the most important thing in this patient was the striking loss of appetite. So the patient always complained that she's not able to eat anything, and specifically when food like rice is kept in front of her, she feels aversive and she wants to vomit. One more striking feature which I have put it in the red is the fluid overload state was going on with the current dry weight. So whenever the patient was dialyzed, the staff used to keep the dry weight which was on, and the patient again had edema in spite of reaching the dry weight which was set at that point of time. Please remember that the patient is not eating food for almost 2 to 3 weeks. Now the patient has received multiple antibiotic course from the local physician there. So every time 5 days fever, 5 days antibiotics, patient feels better. She doesn't come for follow-up, 2 weeks gone, then 2 weeks gone, and the antibiotics course is just repeated. Sometimes it is levofloxacin, sometimes it's azithromycin, sometimes it's cefixime. So this thing is going on. Now what happens is because the dry cough is persistent for almost 1.5 months, patient is not having good appetite. The pulmonology reference was sought by the local physician. Now the doctor advised, because of the dry cough ongoing, an HRCT chest. So when the CT chest was done, the diagnosis was tuberculosis. So there was this in the apical regions. You can see the shadows on the CT, which was for which he had to do a bronchoscopic alveolar lavage because sputum was not showing any particular acid-fast bacilli. So how does tuberculosis affect the body? Patient can have coughing, they can have chest pain, they will feel fatigue, there can be trouble breathing, breathlessness, they can have intermittent fever, fever will be normally around 100, they can have night sweats. Most importantly, there will be loss of weight, loss of appetite, and certain, if there is a joint involvement, then there can be generalized aches and pains and arthritis-like features. So this all can be a part and symptom complex of disease tuberculosis. So when that left apical scattered lesions were seen, bronchoalveolar lavage was done, which showed acid-fast bacilli, which positive, so that was termed as tuberculosis, and patient was given anti-tuberculous treatment for the course of 6 months. So what are the points we learned from this case? That all fever again is not dialysis catheter related fever. Ongoing, whenever there is an infection, imaging helps in getting the diagnosis early. But one more very important point which you can learn from this case was about the dry weight assessment, which gives an idea of general health. See, if this patient considered to be 60 kilo was the dry weight of the patient when the patient came to the hemodialysis unit, she came with 62 kilos in weight. So the weight gain was 2 kilos. So ultrafiltration was kept as 2 kilos. Now, due to the illness like tuberculosis, the patient has lost appetite, not eating for 3 to 4 weeks, and the patient had lost 4 kg weight. So now what has happened, the ideal weight of the patient has come down to 56 kilos. But what was the dry weight set at this patient was 60 kilos. So now when the patient is coming at 62 kilos, ideally there is a 6 kg weight difference. But every time 2 or 3 kgs was removed. And because of that, the patient was getting into fluid overload state. So in the previous slide, when you look, it was mentioned that the patient was always found that being on the current dry weight, the patient was always having a fluid overload state. And because of which, wrongly, the dry cough was attributed to the particular fluid gain, and it was not considered anything else because always the dry cough, that is because of the fluid gain. Because you are not able to achieve the dry weight. That was the point discussed. But it was a misnomer there. Actually, it was because of her personal weight going down and not titrating the dry weight, causing the fluid overload, also adding up to that cough and helping the infection to spread. So it is very important to assess the dry weight when the patient is sick. That's what we could learn from this case, along with the common symptom fever can sometimes present as abnormal as tuberculosis. Now coming to case 5. So it's a diabetic nephropathy chronic kidney disease on maintenance hemodialysis 3 per week, complaining of tingling and pain in the lower limbs. Now the patient has got tingling and pain in the lower limbs. Some common symptoms for diabetes for long-standing diabetic patients is peripheral neuropathy. They have this from the pattern till the gloves which you wear in the hand and the socks which you wear in the legs. Till that point, these people will have this sort of peripheral neuropathic symptoms. So patient was put on a tablet of gabapentin 75 milligrams to feel free from the neurological symptomatology. Now what is that? Also the patient was given vitamin B12 to support the particular symptom. Now symptoms did improve much as expected. So the patient did not feel much better, but we all know that peripheral neuropathy once set in is almost nearly permanent, but we can give some relief to the patient. So every time the patient kept on saying that the pain persists, but doctor on duty or rounds would say that this is part of your peripheral neuropathy, So that is why you continue this tablet. That is what maximum we can do for you. Now what happens is, because of the continuous symptomatology, they referred themselves to a neurologist. So when the neurologist saw the patient, he diagnosed the patient with restless leg syndrome, and they put the patient on a tablet called as ropinirole, which is along with gabapentin, which helps in the treatment of restless leg syndrome. For all of you who have not been able to attend the neurological complications of dialysis class, restless leg syndrome is basically the patient finds the presence of aches, something is pulling in the legs, some sort of itching in the legs, sensation of bugs under the skin. So some worms are walking under the skin feeling, tingling feeling, tightness feeling, and electrical joint sensations. So these all symptomatology, one or together, explains restless leg syndrome. And the treatment for the same is ropinirole, or pramipexole, pergolide, and gabapentin. In some cases, even levodopa is used in severe cases. So any of these combination of drugs are given for this particular syndrome. So in this case, the neurologist diagnosed him of having restless leg syndrome. Now what happens? Now he was fine for 4 weeks with those sort of combinations. But now again he complained of pain in the lower limbs. Now since he had been evaluated before for the same, because so much of test was done, evaluation was done, the local medical team advised to continue the same medications. So the doctors already saw the file, there's already neurologist has seen, diabetic neuropathy is present. So they said to continue the same thing. Now his pain worsened. And also, after 1 week, he developed light bluish discoloration of the second and the third left toes. So looking at the discoloration, they then advised for arterial Doppler study, and they found that there is decreased flow in the proximal tibial artery as well as the dorsalis pedis artery. So there was definitely some sort of obstruction or stenosis, because of which there was decreased blood supply to the particular part, and that is why the discoloration and the pain was mainly ischemic in nature. Now what happens is, patient undergoes peripheral angiogram and they find a tight stenosis proximal end, and now they identify the spot, do a balloon angioplasty, and the peripheral circulation is restored, and slowly the patient's symptoms improve. So what was the point here to ponder is that every time there can be a common presentation, but the disease may be different. So here, the patient initially was diagnosed as peripheral neuropathy, which is also true in a diabetic. Then the neurologist diagnosed the patient with restless leg syndrome, which also he was having. And later on, when he complained the same complaint of leg pain, then finally we found out that third time the patient was actually having a peripheral vascular disease, which could be improved by doing a angioplasty. Case 6, a 70-year-old male on maintenance hemodialysis 3 per week has now come with a complaint of knee pain. Now, in view of no urine output, painkillers were given. Pain subsided by the following session, and the patient X-ray was advised by the orthopedic, which was done last month, and it just reported as osteoarthritis of the knee joint. So here the patient's complaint is a simple knee joint pain, and patient subsided pain with some painkillers, and painkillers was given because 1 month back the orthopedic has diagnosed the case as osteoarthritis. Current scenario is not what the thing is being taken into account. What has been diagnosed last month because of the similar symptom is what has been taken into account. Now after a few weeks, the patient again complains of severe knee pain now. Now it is only onto the right side. Now he is not complaining pain on both sides. He is saying that the right side is more, and it has become very much high in the last 1 day. Now when you examine locally, it shows a little boggy swelling. So there is some swelling around the joint, there is some pain and tenderness. There was warmth also, so there is some temperature also around the joint. So you can see this, what has happened in this patient. The other leg is almost normal. The leg facing your screen is having a redness. There is some sort of a small wound there, and there is some inflammation in the part. The warmth is there. So basically the cartilage and the synovial cavity, the fluid is inflamed, and it now contains bacterial infection, and it is called as septic arthritis. So an ultrasound knee joint with aspiration was done and aspirate was sent for pus culture. Antibiotics were started regarding the same as per the culture sensitivity, and the diagnosis here was septic arthritis. So we realized that the complaint is same 1 month before diagnosis osteoarthritis, but if you don't look up to the knee joint, if you don't do a what we call as clinical examination is key. So that is the main point to consider here. Clinical examination is key. Warmth, redness, tenderness, and differentiated really differentiated the case from osteoarthritis and septic arthritis. And aspirates which we send for pus culture gives the appropriate antibiotics. So it is our duty that when a patient is shifted for ultrasound or any test for aspiration, you must give an order from the dialysis unit that we need a culture for the same. Coming to the last case, the case 7, a 54-year-old male diabetic hypertensive chronic kidney disease on maintenance hemodialysis 3 per week. Now here he is on history of migraine for which he was on prophylaxis. Now this patient is having already a history of migraine and headache. Now he came to the unit with complaint of headache. Now when his complaint was on, his blood pressure that time was 180 by 110 millimeters of mercury. Now he underwent hemodialysis and by the end of dialysis he had a seizure. Now he was stabilized and a CT was done. And now the CT is showing a small, very small hemorrhagic stroke. So he was admitted, treated conservatively because it was just a very small hemorrhagic stroke and discharged. So what happened? A patient with a history of migraine had a accelerated hypertension, following which during dialysis he had a hemorrhagic stroke, but it was a very small hemorrhagic stroke. It was treated and the patient was discharged. Now what happens is, over a period of 1 year, 2 years after that, this patient had a multiple episode of headache. So sometimes when the patient's headache was there, BP was also high. Sometimes the patient used to tell by himself that he has got migraine because he has had coffee in the morning. Coffee stimulates migraine, so that is why I am having this headache. And used to take the tablet for migraine. No further neurological opinion was sought after that, after the first episode of hemorrhagic stroke. Never was the patient ever reviewed by a neurologist. Neither did he have any focal neurological deficit at that point. But sometimes his headache was persistent. One fine day, he presented with seizures. Now he comes to the unit, dialysis going on, seizures and a cardiac arrest. Now we did the reviving part of it, stabilized the patient and sent the patient to ICU. Once the seizure was under control, patient is stabilized, then an MRI was advised. To assess the neurological status, he underwent MRI. MRI showed a mass lesion, a tumor-like lesion in the temporoparietal region. That was reported as grade 4 astrocytoma, and patient had to be referred to oncology. Now when you look at this case, when you look at the points to ponder, the patient had a similar presentation as headache, but 3 different situations. One situation, it was about accelerated hypertension. One situation, it was his primary problem, migraine. And the other situation is such that we are always thinking it is hypertension and migraine, but now the patient has got a brain tumor. So each time it is important that we have a proper evaluation and imaging should be considered. Other common symptoms which can present, which you should be keeping in mind is fatigue. When a patient complains of fatigue, you should always think about 2 things for sure. Infection, because elderly population do not have fever sometimes. They only present with fatigue and sleepiness. So in that case, they will find a WBC count very high, treat with antibiotics and the patient is fine. And also specifically electrolyte imbalance, specifically sodium. So some patients who have got low sodium, they will be having extreme fatigue. Some people present with loss of balance. So whenever a patient says they're walking, I go one side, right side, left side, we should consider that there can be a possibility that a patient who takes an antihypertensive medication in the morning puts him into a state of hypertension, something below 90, 95, 90, 85, that blood pressure systolic, which is causing the symptoms of loss of balance. It can also have neurological symptoms like Parkinsonism. It can also because he has got a profound peripheral neuropathy. It can also be because the patient has got Wernicke's encephalopathy. And the other thing is about abdominal pain. Patients who have got abdominal pain can be because of simple cramps also, or it can be something intra-abdominal pathology. Sometimes a lady with hemodialysis had a big mass lesion. It can be because of even pneumonia. Sometimes upper abdominal pain can be because of a left lower lobe pneumonia. It may not present as cough or fever. It may just present as abdominal pain. Sometimes epigastric pain can be just because of a heart attack, myocardial infarct, or it can also be a pancreatitis in a patient of dialysis. So we have to look into these symptoms, very important. But my most favorite and all time, whenever I take a lecture, I talk about this symptom, that is yawning. So whenever you see a patient in your dialysis unit who was absolutely fine few minutes back, now suddenly yawning too much, you must go and check the blood pressure. You may find that the patient had come to the unit at 180, 200 BP, and currently probably the blood pressure may be as low as 90, and he's going into further hypotension. You can pick it up early whenever the patient is yawning, unless he's in very deep sleep. So take-home messages for the talk today is that patients complaining of same symptoms each time should not be typified that this is because of the previous one. And a fixed diagnosis should not be considered. Each time the symptom, each time a new evaluation should be done. So proper clinical examination should be done each time. Imaging when indicated should be done. Blood culture at the onset of fever should be followed strictly. And keep an open mind. Please listen to the patients patiently. Thank you.